Hello and welcome to Face to Face on City TV. My name is Umaru Sandamado. My guest today is the head of the National Health Insurance Scheme, Dr. Da-Costa Aboagye. We're going to talk about the scheme which was started many years ago under the Kufuor administration, which scheme is hoping that by 2030 something significant would happen. How are we faring on that path to having universal access to health? That's a conversation we're going to have when we come back. Please stay with us. So my guest has been in the health space for some time now. Recently, the president decided to do a shake-up of his government. He moved the man who was heading this particular scheme, the National Health Insurance Scheme, to be the Minister for Health. He's waiting parliamentary approval. But while that's happening, there's a need to fill this vacant office because it's a very critical office. So the president appointed someone who we've known about communicating for the health sector since COVID and even before COVID, Dr. Da-Costa Aboagye, to head this particular institution. Let's have a conversation with him. Congratulations, Doc. How are you?
Thank you, my brother.
How is it looking here?
Well, it's good.
Nice.
Very busy, but it's good.
You're a new boss of an old place. 2004. That's how long ago since the NHIA was set up. So, 20 years now, right?
About 20 years, yeah.
Are you putting a big party for 20th anniversary so we'll come and celebrate?
Yes, I think there's a year-long activities that have actually been planned,
Okay.
a series of activities. It started before I joined,
Okay.
Which obviously is going well as we speak. Yes, so
I see. But how are you fitting in? This is your first time working in the health insurance space.
Okay, thank you. I think yes, it's my first time, but I think it's not new to me because this is my area of specialty.
Okay.
But I did my PhD in healthcare financing, specializing in the National Health Insurance Scheme.
Okay.
So in 2010, I was in this country. Even though the university was abroad, I was always here doing my data collection. So I have known almost the CEOs from 2010, working with them and some of the staff. And because I was also the director of health promotion at the Ghana Health Service, I mean, you know, insurance and Ghana Health Service, we do work together. So I'm really familiar with the terrain. And yes,
you've known the CEOs. You're incidentally the 9th CEO of the NHIS in its 20 years lifespan.
Yeah.
Let's talk about you as a person first of all. What's your background?
Okay, thank you. So I had my master's in public health promotion from the University of Leeds Beckett University in the UK, Leeds. Then following that, I did my PhD in National Health Insurance Scheme, looking at the policy, looking at it from equity, from health economics, and also from the social protection angle. But before my master's, I attended the University of Cape Coast, where I studied chemistry. In fact, I'm a disappointed doctor.
Oh,
yeah. Because because in the third year, we were supposed to obviously branch into the medical field. But somewhere the university was not ready at the time, so we had to choose between the physical sciences. And so looking at
UCC was not offering medicine at the time?
At the time, well, when we started, it was one of the things on the table that by the time we get to third year, it will be ready. But unfortunately, it was not ready at the time. So I decided to do chemistry because my background is actually pharmacy technology. So it was in sync. So I did that, and I did my national service at Interbeton, like Central Regional Hospital. Okay. So yes.
So you are a pharmacist by profession?
I'm a pharmacy technician.
What's the difference?
Okay, so the technician is the technical aspect of pharmacy. But the good thing is, when I was in the UK, I specialized in what we call medicines management. So I was in the consulting room with doctors talking about contraindications and all the other things, guiding medical doctors.
So for you, the NHIS has always been your end game, even though you may not have known about. I'm sure when you're in primary school, if you knew what NHIS was, you would have said, "My dream is to be CEO of NHIS." Because pharmacy is like when we go to the hospital, the dispensary, they give us a drug, and that's where a lot of your money goes to NHIS, to the hospitals.
And that is actually my background in terms of what I studied at the Polytechnic. It was Kumasi Polytechnic. Now I think it's the Technical University. Now you are letting me miss my school.
But it's not going to be a walk in the park, because you see, a lot of the times being a CEO of NHIS doesn't require you necessarily to have expertise in health issues. So for instance, Akufo-Addo's first minister for health was not a health person but an accountant. And we were told, the president himself told us why he put an accountant in charge of the health ministry. So the fact that you have a health background does not necessarily translate into you being a better manager of the space. Convince us that you will be a better manager.
Okay, thank you so much. You know, I've also been in top leadership throughout. Since I completed school, I've been in top leadership positions. So if you look at where I was working in the UK, I was the cohort lead for public health and health promotion programs. That is how I rose. What I became in the United Kingdom at the West London University. Now, when I came here, I was actually the director of health promotion. Currently, just about 3 days ago, I was the chair of the ECOWAS Risk Communication and Community Engagement. So I handed over just last Friday. As we speak, I'm the chair for African CDC.
Center for Disease Control.
Center for Disease Control, Public Health Promotion, in charge of risk communication and community engagement. So you can see the trajectory. I've always been in top leadership positions. And I think what makes it even interesting is, like you rightly said, my background. Now, it helps because this is what I've studied, so I have in-depth knowledge in. Now, it's how to translate the theory into practice. So, what do I bring on board new? And this is where I say that I have 4-point agenda to help shape the scheme.
So, what do you bring on board? 4-point agenda, agenda 1.
Okay, so I've noted that within the primary health care pillars, but let's say that the National Health Insurance Scheme funds primary health care. Now, within the primary health care space, there is a critical component that, to me, has been missing for a very long time. It is being funded through vertical programs, but I think when we mainstream it, it's going to help. That's promotive preventive benefit package. Now, since the inception of the scheme, we have not considered the preventive and promotive benefit package.
Explain what that concept is.
And our forefathers actually told us that prevention is always better than cure. Now, that concept entails preventing diseases before it happens. There is no social insurance scheme or a national insurance scheme that will survive if the determinants of health are not funded. Now, there's a rise in non-communicable diseases, hypertension, diabetes. How do we as a country position ourselves in such a way that we reduce the incidence in its worst form? So
reduce the cases as much as you can.
Reduce the cases as much as you can.
But you can. NHIS, you are not a health service. You are not a Ministry of Health. Okay. How can you go and engage in preventive campaigns?
Okay.
When you are supposed to engage in mass registration of NHIS members.
Okay. Now let me take my time and explain to you.
Please do.
Okay. So, like I said, there's no insurance scheme that will survive without funding the determinants of health, which is anchored on promotion and prevention. The SDGs 3 actually talks about health and wellness. Okay, the health aspect is actually normally covered, but the wellness is sometimes a problem in many countries. Now, within this promotive and preventive approach, focus is on wellness. how do we make sure that within a life course approach, Ghanaians will have the best health care right from infants to growing up. So within the promotive preventive benefit package under my leadership, the NHIS will be offering a one-time medical check annually for each citizen.
How? So I can go to the hospital and say I'm coming for checkup, and it will be free or covered by NHIS. Is that what it means?
Okay. So every Ghanaian do pay for the NHIS through direct and indirect means. Okay. So when I appeared before Parliament, I made the argument that the next pandemic is the non-communicable diseases. So we need to reduce the incidence of the non-communicables. In reducing that means that we have to start screening the diseases early. So this is why within the promotive preventive benefit package is a huge listing, but we have singled out only one, which is the medical check, in such a way that we're able to detect the diseases early. Now, how do we do it? So on our database, we do have about 25 million Ghanaians who are registered members. Active membership is about 17 million. We have their details. So we'll be working with the telcos in such a way that we send text messages to every Ghanaian, or those on our database, at least for a start, that when it is their birthday, they should go to the various health facilities to have a basic medical check. And I say a basic medical check defined by the NHIA. Now, when I was in the Ghana Health Service, we started a pilot with funding from the USAID under the Accelerating Social and Behavior Change Project, under what we call the wellness clinics. So most of the district hospitals do have the wellness clinics. But my proposal will not need the wellness clinics in a way, but it's a critical component of it. So it's just starting with it by, let's say, if your birthday is today, you get a text message, your nearest health facility, just go, have your vitals, it will be defined. So a team from the NHIS with all the stakeholders are working on that benefit package. We have seed money from Parliament to continue, obviously, to put it into shape. And I'm hoping that as early as next month, this can start, because it wouldn't take time. Already we do have the members in a way. Now, the argument is, do we have to cover the non-Ghanaians? The non-members. Mm-hmm. Now, my view is that we should cover them, but we should make them to register, because by doing this will boost membership, because when you are going, it's an incentive. So when you are going to the hospital to do your basic check, we would register you and onboard you.
Okay, but prior to this, your agenda, if I went to the hospital to be checked because I'm not well, my vitals will be checked. I don't pay for that, do I?
No, you pay. Okay. it's not part of the package.
So NHIS does not cover my blood pressure and those things.
Unless you are sick and we are determining the diseases.
Okay.
But this time, I want it for healthy and non-healthy Ghanaians.
So if I went to the hospital on NHIS, I have a headache. I get to the hospital. They say, go through your vitals, climb that thing, let them check your weight.
You have a headache.
Yeah.
How can we prevent you having the headache or the subsequent diseases?
No, my question is that currently, are you saying that the checking of vitals in the hospital and an NHIS policy is paid for outside the program? Is that what you're saying?
Okay, so currently, what happens is, if you are sick and you go there, we will check some of your vitals. Mm-hmm. Some, okay? Not all.
Okay.
But what I'm just saying is that every Ghanaian,
and that's because I am sick. So you're
because
saying
you
that
are sick.
Because now I can go even if I don't feel sick.
If you don't feel,
and it will be checked for me.
It will be checked for you
for free.
For free.
And it will cover what and what.
Now look at what it does first before we. Now this is what it does. You see, like I've told you, every Ghanaian pays for the NHIS. So it's an incentive, like you said, for every Ghanaian to boost our membership. Okay. 2, it addresses the equity components, because our focus within the NHIS is to address the equity. Okay, so it means that you are giving access to every Ghanaian. And 3, we need to achieve universal health coverage. Promotive preventive is a key component to achieving universal health coverage.
Okay.
But I'll come to the other points to help us achieve the universal
Let's move
health
to point
coverage.
2 on your agenda.
So the point 2 is when, like I said, on our database, we do have between the ages of 6 and 14, about 6.3 million out of this 25 million young people who do not even have, obviously, Ghana card, or who do not have, they are on our system. Some do have expiry cards and other things. So when we went to Parliament, there was this argument about why do we keep on producing our cards for the Ghanaian? Then we from the NHIA said that it will be prudent spending to cede our money to the National Identification Authority to produce Ghana card for the 6.3 million Ghanaians on our database without a Ghana card, to save cost, to avoid double spending. Because at the end of the day, the NHIA, the NIA were going to do it, but at their own pace. But we believe that by giving them the Ghana card for access, because we are doing integration, it will facilitate us achieving the universal coverage. So Parliament approved 3 million of the cards for us, based on the sound argument that we made, to make sure that they've asked us. We've signed the MOU with the NIA, and last Saturday the training have actually started. So we are on course to producing these cards for these young people.
How soon before these cards start coming out?
Very soon. I'm sure once we sign the MOU, it's just the procurement processes. So we submitted it to the procurement authority to make sure that legally we are compliant.
The reason I ask is because those who have already applied for the Ghana card, in the regular sense of the application, a lot do not have their cards. So if you haven't fixed their own backlog, what's the guarantee that they can fix yours?
No, they'll prioritize ours because obviously we are paying for it.
Okay. We also pay for it.
And it's on our database. The NA, I don't know if you pay for it. It's the NIA that pays for it. So they have their budget too.
Okay.
Yes. But this time, what we are doing, instead of producing our cards, which costs between $5 to $6, the Ghana card costs about $6. So we are actually
get the Ghana card. So this will be giving Ghana cards, but which are also NHIS cards. That's your plan.
Yeah, based on the integration. So they will be giving Ghana card integrated with the NHIA.
While you are at that, what is the grand agenda to integrate those of us who were already having health insurance?
That is actually ongoing. That's actually, it's going, in fact, currently.
So there's a linkage happening?
There is a linkage happening now. So this is why you see it's very important, because Ghana Health Service is now doing number at birth. So if we cover 6 to 14, then from 15 onwards, it's already covered. You see, now with that, the only thing you have to do to achieve universal health coverage is to remove the cost component, because bear in mind, by that you have formalized the system. The informal sector is huge and it's a burden to us.
So wait, if I currently have a Ghana card,
Yes.
I also have an NHIS card.
Yeah.
What am I supposed to do the linkage? We saw what happened with the telcos. What am I supposed to do with NHIS?
I think you just need to star 929 hash. With the star 929 hash, you are done. The integration will
So
be done.
I should do that on my phone?
On your phone.
And connect my NHIS to my Ghana card?
Yes.
What that means that if I want to go to the hospital, I show my Ghana card and I'll be taken care of?
Yes. I can tell you that Ghanaians aged 15 and above have started using their Ghana card to access
in the hospitals.
In the hospitals.
Your NHIS cards, I haven't used it. I haven't gone to hospital in a long time, and I'm happy I didn't, or I don't. But at the back of my NHIS card, you had these nice reflector stickers, which you use to determine whether it's expired or not. I don't know if that's what you still produce. I haven't gone to hospital. How do you ensure that my health insurance is not expired?
Great. So you see, you made a very important point. You said you have the NHIS card, but you've not used it. You see. So as part of my research, Ghanaians told me that they are not benefiting from the NHIA because they have to wait to be sick before they actually access healthcare. So to them, there's no point registering. So this is why I'm saying that under my leadership, the NHIS or the NHIA will take a bold step to incentivize Ghanaians to at least give everyone the opportunity of once a year medical check.
Okay. So but my question still is,
no,
how do you check?
I'll answer your question. I'll answer your question. So once we put these processes in, it's just a simple reminder to just tell you that your NHIS card, renew your card.
Okay.
And you see, the good thing is that the Ghana card actually lasts for 10 years. So it's just a constant reminder
that you need every year. Just by way of quick information, how much does it cost to renew health insurance now?
I think it's 8 cedis.
8 cedis.
8 cedis, yes.
For everybody who's having the card for a year.
Yes, for a year.
Is that good for you guys? Is it helping you?
You see,
is that enough?
Let me now tell you something. You see, I have explained to you that we have an agenda. You see, and the agenda is to achieve universal health coverage, giving free access to healthcare to everyone, or giving access to healthcare, or affordable healthcare to everyone. If you look at the premiums on our budget, it is less than 3% of the entire budget. But I know by my expertise that once you remove the cost component of registration and the premium, you achieve universal health coverage. That is if you formalize the system.
Okay.
So to me, the argument is it's just a matter of time.
Very well.
You see,
let me take a break. This is Face to Face on City TV. My guest, Dr. Da-Costa Aboagye. He's the CEO of the National Health Insurance Scheme. We're talking about his vision. He has a 4-item agenda that he says he wants to fix. We talked about 2. When we come back, I'll ask him to elaborate on the other 2. Then we ask about this thing where you are not well, you go to the hospital and they say to you, wait there, NHIS and Covao. How are they going to deal with these matters? It keeps coming up every now and then. Please stay with us. You're welcome back. This is Face to Face on City TV. My name is Umaru Sanda Amado. My guest, Dr. Aboagye Da-Costa, or Dr. Da-Costa Aboagye. He's the NHI's boss, newly minted. He's just a few weeks old in office, but he's looking stressed more already. Please, I hope you've been getting yourself checked yourself. Yes. You've been getting yourself checked. Please do get yourself checked because the pressure is too much. You've talked to me about the first 2 things that you have as priority. You talked about health promotion, where you invite people on their birthdays at least to go and get a checkup every year. You've talked about it. You've talked about the linkage between the database of Ghana National Identification Authority and NHIS. What are the 2 other things that you have on your plate? Okay,
thank you. So I think in our act, non-Ghanaians are actually within that. We have to cover non-Ghanaians. And as part of the universal health coverage agenda, I think it is important that non-Ghanaians or visitors visiting our country should also be insured to have health insurance. And this time it should be mandatory health insurance for visitors visiting Ghana.
Even if it's not for long-term visits?
Yes, because you see, it's good for them, and you see, when you are visiting, actually, regardless of the time, you protect the citizens and citizens protect you as well. It's covered in the Public Health Act. You see, I realized something. When we had COVID, you know, people coming to this country had no insurance. Had they had insurance, government would not have been paying the medical bills initially for such people. You remember initially we had to cover for all Ghanaians.
Recently I applied for a visa. They told me to bring health insurance. Is it travel insurance? Is that the same thing you're talking about? So we should have something like that
if we have something, yes. So we are yet to determine the model. Okay. A policy has been launched already, but it's not been taken up. But I really want to make sure that the NHIA takes this up and make sure that visiting people coming to this country should have at least a mandatory health insurance. Then we designate facilities to take care of them. It's good for the country because, like I said, it protects them in a way.
Just by way of checking, have you checked with a sub-region to see how we are faring against other schemes in the sub-region?
In fact, you see, our scheme seems to be one of the most prominent within the sub-region. And it seems to be a model for most of the countries in the sub-region.
Okay.
And it's really strong.
Okay.
It's the largest social protection scheme within the sub-region.
Better than Nigeria?
Of course, better than Nigeria. Covers only 2% of the population.
Let's talk about a comparative analysis with the private health insurance schemes we have. Why do lots of private companies decide to enroll their employees on private insurance companies if you are doing so well then?
Okay, great. You know, we regulate the private insurance.
Yeah, but they're still beating you to a lot of
No, they're not. If you look at our numbers, they are not close to, they are nowhere close to.
But people feel comfortable or more comfortable with them.
You see, look, that's what I'm saying, that you see, it's just, you regulate them, so you put the regulations there. So it's individual choice where you want to go. But again, you see, our social insurance scheme is mandatory for all Ghanaians. So it's not to say that companies do not have the right to go to other. I mean, for us, even for the MPP government, for me, it's our priority that private sector participation is actually encouraged, because that is our call, something that we pride ourselves about. So for me, I don't have any problem. You see, the fact is, how do we strengthen our insurance scheme in such a way that people will be confident in accessing healthcare and using that to achieve universal health coverage? And I'm talking to you about reforms that will make people obviously access healthcare through the National Health Insurance Scheme.
Okay. The question I asked before we went on break is where people would say NHIA doesn't cover A, B, C, D. But
that's the fourth one that I'm coming to.
Yeah, so their private insurance will cover. So your fourth one will deal with that. Let's go to the fourth one.
My fourth one will deal with the issue of, obviously, illegal payments, but I'll cover what you've just asked. So I've noted, I've met with Ghana Health Service, I've met with CHAG, I've met with the private health facilities. There is a problem. The problem is there are illegal charges within such facilities. And I propose a formula to stop that. And what I'm proposing is, where we look at the current scheme. Currently, my team are doing the tariff adjustments. They are reviewing the tariffs. So once the tariff actually comes to place, then we will seek approval from Parliament to see if we can implement what we call automatic price adjustment, like we do in the fuel field. It's one of the models that you can use. So there will be a National Technical Review Committee for the pricing. Then you tie that against inflation and other, so that immediately you see that, I mean, obviously things are going up, then the committee will meet with the various stakeholders to determine the pricing. When things are going down, they also meet. Currently in our act, we have to review it once every year. But I think if we are able to come up with this National Technical Review Tariff Committee to actually look at the market and say, no, the price of paracetamol is this, so the NHIS must pay it for, then that will be disincentive for providers to actually charge our clients. And once we do that, then providers will have no moral right to actually be turning our clients away that this do not cover under the NHIA, or they will have to top up. Now, let me finish this. There should be sensitization on what we cover. That's why when I started, I told you we only cover primary healthcare diseases, about 95% of the primary healthcare diseases. So we don't cover everything. 5% is actually not covered. And most of the tertiary cases, we don't cover. So if you are not careful, as you sit here, you may not even know what your entitlements are under the scheme that you've registered. So I think there's a deficiency there that we need to address. So along the automatic price adjustment formula that the NHIA will be proposing, it will go along with a comprehensive health education for citizens to know their benefit package.
So the pricing thing that you talk about, this is a cost of services or cost of drugs?
It can be cost of services and cost of medicines. You see, because when, in this country, there are indicators that drives cost. So once you know that those indicators are driving cost, then the tariff review committee can now meet.
But if they meet and they say that NHIS, this is how much you're supposed to pay, meanwhile, the amount you are collecting cannot take care of that. It means that you are also then going to the
Who
complete...
told you that?
Okay, tell me how... Because if the committee comes to tell you that because of Russia and Ukraine, paracetamol has moved from 5 cedis to 15 cedis, NHIS, this is how much you're supposed to pay. Meanwhile, NHIS collected 7 cedis from me. Are you going to come back to me and ask me to also then pay 10 cedis or 15 cedis? Because I'm looking at the end user being the one who suffered, the customer or consumer eventually suffering.
Okay, so thank you. Now let me, at this point, affirm to you that the NHIA is sustainable. Okay, the only thing is we just need to reduce the cost burden vis-a-vis the diseases. Okay. This is why I have told you that under what we provide, under what we cover, when you do the actuarials, we are in shape.
Okay.
The collections are a lot. Every Ghanaian, when you buy anything, you pay for it. There's a levy. And there's direct tax also by salaries. There's a net contributions as well.
And there's a premium.
And the premium is what I've told you that to me is insignificant because the amount is too small.
There's a bigger.
So you see, once you formalize the system, in fact, revenues will actually increase because indirect and direct taxes will
coming in.
Yeah, they'll be coming in.
I have a question.
And wait. And when you actually bring on board the visitors' health insurance,
you expand it more.
Okay. You see, so you see that the revenue will actually be increased.
I have a question from a very ignorant point. When SNIT collects my money, they invest it in so many things that I see, hospitals, several other projects. When NHIS collects my money, where do you invest that money?
Okay, so...
Do you just keep it in a bank and be paying the hospitals as they demand, or you invest it and turn over?
No. You see, as part of our mandates, we are to invest. So what I know is that they do have investments in, like I said, I just came in, so I'm now obviously taking my time to obviously abreast myself with. But even, I've been briefed on a couple of investments that we have been investing in by the Deputy Chief Executive Officer in charge of finance and investment. But obviously, one of our core mandates is to invest. That is, if we do have the money in excess, we can obviously. So now you need to also make sure that you are fulfilling your primary functions, which is paying the claims to the facilities so that our members will. So if you look at the trajectory from the last since 2017, government is on course. For lower tiers, we've paid up to December. This month, we are paying January. For higher tier, we will be paying November. So it means that we are, in fact, the at 650, which has been replaced by at 852, stipulates that within 90 days, we were to obviously pay. So if you look at the lower tier, we are actually in tune. The upper tier is where we have a gap. So we owe about 2 months or so. But we are trying so hard to bridge the gap. Okay, so in doing that means that we are obviously on course.
Okay, my next question is, you have a universal agenda, or you have an agenda to ensure that by 2030, and I think that's an SDG goal, that by 2030 there's universal health access. Is that to mean that 34 million Ghanaians, as we have the number now, everybody will be on the scheme. Is that what it means?
Yes, having access. You see,
so currently we have 17 million people
active members.
Okay. Which means you have a shortfall of how many?
Oh, just deduct it from there.
Okay. You have 6 years to 2030.
Okay, so I'm just proposing a formula to achieving this. And I'm saying that our biggest problem is the informal sector. So once we formalize it with the Ghana card, okay, which is my second vision. Once you formalize it, okay, then you remove the cost component of the premium and the fee. Everybody will now have access to, because you are integrating as you go.
I'm looking at the projections. So
I even think we may even achieve it lower than earlier than the 2030. That is, if we put our house in order.
So you're tying your hopes to NHIA. You're saying that
not NIA,
the
NHIA.
issuance of Ghana card to people would be your ultimate.
Of course, it's our trump card.
So for you, it is your desire that NIA expands and gets universal access. If that happens, you also get yours.
Okay, so it is my hope that NHIS should integrate with NIA in such a way
but
that...
But before they integrate, they have to make sure everybody gets a card.
The card.
Okay. Before
and this is why we are offering to pay for the 6.3 million.
That are not covered
That
by
are
them.
not covered. So once we do that, then universal health coverage is in sight. But we have to remove the cost component, which is the fee and the premium. Which to me, I have told you by my actuarials or by the things I have done, it's insignificant on our budget. So when because last year, it was 260 million out of 4 billion. Work the maths.
That's direct payments.
That's the premium.
Yeah, that's a direct payment.
No,
that's where someone pays.
Yeah, direct payments in our facility and in our centers.
So the 8 cedis payment.
Yes.
So you are saying that thing should go off?
To me, you see...
What does the law... The law says it should be there, right?
No, wait. You see, for me, it's work in progress, okay? Before you are able to do that, there are certain things you have to put in place. And I'm giving you the formula by my expertise that I believe that with the government agenda of digitalization led by the Vice President, we are likely to achieve the universal health coverage even before the 2030. Should we go on the trajectory of the Ghana card?
Good. I got you
integration there. With the...
I got you.
Yes.
What I need clarity on is the premium that you are saying is sort of... It's plenty of money, but it's insignificant in the scheme of things. I'm saying that. What does the law say currently? Does the law say that you can at will scrap the premium?
No, I think you need to pay. At the moment, we need to.
Okay.
We need
so how do you remove that?
You just have to go to Parliament.
Are there processes to do that? Because that's my interest now. So that you say to Parliament that, listen, people pay when they go to the shopping malls. People do A, B, C, D. There are indirect ways of paying. Let us keep that. Let's scrap off this.
I think there must be deliberate government policy.
Okay.
Too. You see, you remember that at some point another government was offering a one-time policy premium that they couldn't fulfill. You see, so for me, like I've said, it's just a matter of going through the processes, and I want to make sure that I will advise government that they go through all the processes to make sure that all Ghanaians do have access to health coverage without any barrier or financial barrier.
That's clear. Now let's talk about the other side of NHIS. So you want everybody to join. It's exciting. It's all good. But that refrain that NHIS and cover, how are you dealing with that? What does NHIS not cover? You talked about tertiary. How do people understand down there that if they have an NHIS card, it does not mean they can treat everything? And what are you doing to bring those everythings as well on the scheme?
Great. So this is why I'm saying that there must be a deliberate effort to educate Ghanaians on the benefit package that they are actually covered. Because without that, then it means that every time people will be saying, oh, and cover, a cover. You see, so like I asked you, if you know that malaria tablets, which is maybe any of the malaria tablets are actually chloroquine. Yeah, any of the first line treatment, any of them is actually covered. Then you go to the hospital with confidence that, oh, okay, when I'm going, I'll be given chloroquine, but I don't have to pay for it. But it's because people are not aware of what they have to pay for and what they do not have to pay for. That's why when you go and you are given a prescription, pay for this, then then you are just confident that, okay, ebiniho, so I have to go and buy. So I think health education is actually missing in this NHIS advocacy, which I think we have to be aggressive on and bring it and educate the members on. But you asked about things that we have to add on.
Yeah.
Let me tell you something. It's the biggest threat that is facing the scheme. Because you see, we don't just add on. It's a social insurance scheme covering primary health care services, okay? Now, before you advocate for something to be added on, we will do what we call actuarials, to look at the sustainability of the scheme, to look at its cost implication. It is only when we are convinced that when we add on, it will. But in any case, wait, in any case, I'm professing a solution that when we go by the promotive preventive approach, we will reduce the disease burdens. Today, so that we don't get there.
Okay. But you recently added childhood cancers. How has that fared? Or how is that faring?
To the best of my knowledge, it is now being covered. It started last year, so it's been covered.
Okay.
I've not been told of any challenges since I came in, but if there are challenges, I'll try and address them.
One of the major issues we have in the country now, kidney problems, dialysis. Many people have been calling for you to put dialysis on the scheme. I'm looking at a story where a specialist in health insurance payment mechanisms, his name is Dr. Anthony Gingong. He said that NHIS may collapse if it covers dialysis treatment. Is that true? Okay,
thank you so much. So I think, so when I came in, a committee had been set up to look at dialysis and the actuarials to see if it will be prudent for dialysis to be added on the scheme. Currently, that work is ongoing. But from a social protection point of view, or from a compassionate grounds, when we were in Parliament, okay, the NHIS advocated that the committee should continue to work, but at least Parliament should approve some seed money for the scheme to support the very vulnerable or the needy in terms of dialysis care. So Parliament graciously gave about 2 million, which is woefully inadequate, but that is just an emergency fund.
Okay.
Now, following that, a committee has been set up with the CEO of Komfo-Anokye, CEO of Kolebu, Dr. Anthony Nsiansari, and the spokesperson for the dialysis patients to look at the modalities of disbursement of this money. Now, because it is for the needy, okay, now my evaluation actually tells me that in Kolebu, they have a philanthropist who is actually paying about 380 for them, between 380 and 400.
Yeah.
The approved fee by Parliament is 490. This means that there is a gap of 90 to cover for about 300 patients.
Yeah.
And they require about 8 of this dialysis per month. So even if we are able to say that for the whole 300, we are even covering only 2 sessions for them, we've relieved them of a lot. So the mechanisms are now being,
so you are still developing that.
So we are still, but we can't do wholesale, but we really want to make sure that this is implemented as soon as possible. As we wait for the actuarials. So when the actuarials come and it says that when you add it on the scheme will be sustainable, we will make this argument to Parliament to be added on.
This is Face to Face on City TV. My guest, Dr. Da-Costa Aboagye, he is the head of the National Health Insurance Scheme. He has told me how lots of money comes through the scheme or to the scheme through the proper systems that have been put in place to collect money for the scheme. But former President John Mahama is saying that money, the government collects is all right. but it does not give it to the scheme. And for that reason, the NHIS is collapsing. Now, as the CEO, when we come back, please stay. You're welcome back. This Face to Face on City TV. My guest is the CEO of the NHIS. Former President Mahama says, I revamped NHIS when elected president. This was as recently as March 13, 2024. And he said, I'm going to give you a quote from our website, citynewsroom.com. He says, the basic problem is that the NHIS has almost collapsed. This government is not paying money into the scheme. And once the scheme doesn't get money, they also cannot pay the facilities for the claims that they make. And so they are forced to charge the patients when the patients come. What do you say to this?
Thank you. I think we should just go back to 2016, okay? When the MPP government came to power, there was a debt of 1.2 billion, okay, which has been cleared as we speak. Now, last year, by the data, is the only year that through the mid-year budget review, 1.7 billion was added to the 2.7 billion approved by Parliament. In total, last year, the NHIS actually had 4 billion. Out of the 4 billion, about 3.2 and above was actually handed over to the scheme. Every month, government pays between 180 to 200 million to providers.
Well, that's what percentage of total?
Oh, it's monthly. So, I mean, obviously, it's monthly. So you have to do the aggregate for the year, you see. So what I'm just trying to drive on.
So currently, the government has paid you every cent you are owed?
Every
cent that is supposed to come to you?
This will not happen in any insurance scheme in Ghana, in the world. Okay, it will not happen in any insurance, because bear in mind, you collect the money, it goes through vetting, because it goes to the consolidated fund. It goes through vetting and other before they reimburse the scheme. But I'm just giving you the data so that you know that.
So as of end last year, or as of end the last fiscal year, what percentage of what is due you has been given you by the government?
More than 80%, because it was 3.2 billion by the data that I have.
Out of 4 billion?
Out of 4 billion.
So there's some 800 million that has not been given
we've
you.
not lost it. In fact, I've written to the finance ministry. This year, they've approved 6.8 billion. It's unprecedented. And trust me, you see, the thing is, you know, even under the IMF conditions, the social protection funds are protected. Okay, they are protected. So what I'm just driving about is the problem is not actually the inflows obviously coming to NHIA, but the problem is the inadequate tariffs, which government through the NHIA is now professing a solution under my leadership. You see, so you have to separate the two, because if you are not careful, you just miss it and just miss the point. The point I'm driving at is that there is a challenge. The challenge is we've just come up from the COVID era. We've come up from, all economies are actually struggling with escalating pricing. Is that not the case? Our act stipulates that we should review our tariffs once a year. So currently it is being done. So once we do that, then we match to the real prices. And you will see that once we do that, and let me tell you something, under the 2024 budget, we have excess of 30% to take care of, obviously, those increases. So government is really doing very well in terms of the National Health Insurance Scheme.
That is supposed to then mean that you are currently not indebted to any health facility.
Oh, no, we can't say that, because
but if you have all the money you want, then there should be no
indebtedness. Wait, you see, Now, when you submit your claim, okay, when you submit your claim
as a hospital,
we vet, okay, so you see that some of the months, some hospitals might not pass the validation because they've not submitted the right things that they need to, okay. So once they submit, we pay it in the next month. So what this means is that we are on course. It's not, because it's not our fault that we have not actually paid.
What's
but
your
I've told you,
indebtedness to hospitals in Ghana?
Only 2 months.
2 months.
Only 2 months. That's November, December. But we are paying November this year.
November,
this month.
December. We are in April.
No, what did the law say?
What does the law say?
Well, I mean, like I said, under the previous act, obviously it was removed within the current within the current act. But within 3 months, you are good.
You're supposed to take care of them.
Yes, within 3 months, you are good. So we only owe 2 months, even though the Act 852 removed that 3 months. But I mean, if you look at it, it's not really taking shape.
Okay. So for how many hospitals, this November and December, for how many hospitals that are on your scheme are you indebted to that amount, or that duration?
Almost
all the hospitals.
Almost all the higher tier hospitals. Okay. We owe them 2 months, but that is not bad.
And when will you pay them that?
So we are working with the finance ministry, but like I said, we'll pay November this month, which I have the credentials actually on my table. So we'll process it to pay them this November. But I think we'll clear the backlog.
And you are sure that there's money?
Well, the finance ministry will give us money.
Are you sure?
Why would they not give? I told
the finance ministry has no money.
Well, the social protection agency.
It's affecting so many other places. I'm speaking for you. I'm worried for you.
I know, but
because you sound very confident.
I am, because
but you see, the money is not going to come from you.
We've just come from Washington, where I've been part of the World Bank.
You didn't bring a basket of money.
No, wait. But you see, our money is through the taxes and the things you collect.
Yes.
That's where you have to look at it. Our money is not dependent on whether we brought money or not.
That's true. But
you see,
but these taxes failed to fix us. That's why we went to ask for more money from New York.
It doesn't, for me, you see, for me, I have told you that the social protection scheme is protected.
Yes.
Okay. So I'm looking up to government to give me the money to pay the providers.
As we speak, teachers are complaining that they are tier 2.
It's not about teachers.
Just a second. Tier 2 pensions. The government has done the deduction. It's not been paid in their accounts. So I'm just saying to you that government has done the deduction for you, NHIA levy and all of that. But the assurance that it will hit your account is a different issue.
I have all the assurance.
You sound very confident.
I have all the assurance from the finance ministry that they will pay us.
There's something that I have been told about, which is called illegal charges or extortion by healthcare service providers. How big a problem is that, if it's a problem at all?
In fact, it is a big problem. That's why, as part of my vision, which is the third one, I have said that I'll deal with the illegal payments. But you see, you have to put your house in order before you start dealing with it.
Is it not your people who connive with these hospitals to do that?
Well, I have no evidence to that effect, but what I've said is that I want to tackle it from the roots. And I think the root cause is the inadequate tariffs when I met with the providers. So you have to now address that. So I'm saying that there will be mechanisms, and the mechanisms will be, one, making sure that we review the tariffs to commensurate with current economic conditions. Once we do that, then we will seek what we call the automatic price adjustment, which will be a guarantee for the facilities that, you know what, just provide the services, because the National Health Insurance Authority is now giving you a guarantee that even if prices go up,
you are secured.
You are secured. But the problem is, in this country, when things go down,
we don't come down.
We don't come down.
Dr. Da-Costa Aboagye, CEO, National Health Insurance Scheme, thank you for joining us on Face to Face.
Thank you so much.
And my name is Umaru Sanda Amadu. Thank you for watching City TV. Keep watching City TV. It's your world.